unexpectedly, I'm going to be presenting the session on my own today because Carol-Ann Wilson can't join us. So before we start, Happy New Year to you all. Welcome back if you've joined us previously, and also equally welcome to you if this is the first Let's Code Together that you've joined. The first slide explains that MEDRA came about in the mid-1990s. It was an ICH initiative, and at the time, the MSSO, who I work for, was put in place on a contract to maintain and distribute MEDRA. The activities of the MSSO are overseen by a steering committee, which is composed of representatives of both the industry and the regulatory authorities across the ICH regions. Some of these are listed on your screen here. The next slide is about copyright. We don't share the slides for Let's Code, but the recording will be on YouTube. And if you do quote it or use the material in any way, you have to acknowledge that the owners are ICH, and if you change it or do anything, then they don't necessarily approve or agree with your change. So you have to acknowledge where you've changed something. I've explained that we like you to ask questions. You can do this in the comments in the questions panel. Sometimes you may comment and we may not agree on term selection, and we have to agree to disagree, just in the interest of time. We can't take requests to code specific verbatim terms today via the questions, but what we will do is at the end, there will be an option for you to propose new examples for us to consider for the future session. The next one will be in May, but these must be of general interest to the wider audience, nothing so specific that we can't make a learning point from it. And I should say that many of the examples today have come from other suggestions in previous sessions. This is the information you need for joining the polling software. So the polling software is called Poll Everywhere, and you can join in two ways. The quickest and easiest is with a smartphone by scanning the QR code on the right-hand side of your screen. But you can also join with an internet browser if you prefer. And to do this, you go to a browser session and you type into the URL pollev.com. Nothing else, just pollev.com. You then get the screen that you see on the right-hand side. You enter my name, Jane Knight 855, because that's my account. That will link you to the presentation and enable you to join the polling. If you lose the connection during the session, you can use the refresh button on your phone, or the QR code will be on the polling questions. You can scan it again. So hopefully that's enough info for everybody. Oh, I see some of you were there already. Where are you joining from today? This is where I do miss my colleague Carol-Ann because she's very good on the geography. But I see we've got some people from India over, I think that's meant to be Australia there, or might be the India, lots across Europe, Spain, North America, England. Welcome, welcome, welcome. Wherever you are in the world, you're very welcome to be with us today. Turkey, I think I can see there. I'm sure, yes. So here's the details for the web-based browser. We have the web-based browser. Here are the demo credentials that I told you about. We see here on the screen, you go to the MEDRA homepage, how to use, tools, and then on the right-hand side, there's a link. I'm going to use the new web-based browser today, but it doesn't matter whether you use the new one or the legacy browser. Leander's kindly put the credentials in the chat for us already. So if you forget this, you can have them there. And you don't have to use ours, you can use your own credentials. And you can use the legacy browser if you wish, or you can use the desktop browser, or even just watch and not have any browser. So there may not always be an exact match when we code. This is one of the challenges. Sometimes there's more than one possible approach, and we'll see that today in some of our examples. The Points to Consider document also offers us options and a preferred approach and an alternate approach. And I'll explain a bit more about that with some of our examples later. Sometimes it's a case that we understand the term differently when we first read it, and so we have a difference of opinion. So what we do when we code, the way we like to describe it is that we represent the reported events by a best approximation. Overall, we always code as reported without making any assumptions. And we always bring along a couple of interesting pictures to show you how verbatim terms can sometimes not be understood in the way that they were first intended when reported. And here are some pictures that show just like that how sometimes our brain can play tricks on us. Here we see a gate. This gate is in Vienna. And when you first look at it, it looks as if you can walk into a passageway, an archway through into the ironwork there. But actually, it's just the way the gate is built. So very interesting there. Our brain plays tricks on us, and the context can be important. Here's another one. Sometimes it's the case that we don't all see the term in the same way. Who's right and who's wrong? In an example like this one, do we see the panther and the eagle? Is that an eagle? Some big bird? Or do we see the woman's face in the clouds? If you lean back a bit, you see who's right and who's wrong. Who's to say? Well, only the person who intended it would say what was correct, I think. So sometimes we write a query to the reporter and ask them what was intended when they wrote the verbatim. So all these are all principles of coding. Basically, it's a balance between coding rules, which give us consistency, and medical judgment, which is how we manage the risk. Medical references can be useful, and we'll see that later today as well. Sometimes it may be that we need to request a new term to be added to MEDRA, and we have an example like that today as well. So overall, it's a balance. We do the best we can, and having said all of that, then I'm going to turn my camera off and let's code together. So here's our first example, and Leander's going to put it in the chat for us. So if you forget what it is, then the wording, you can have a look in the chat. The wording is graft colonization with Serratia marcescens. That's the first example. We look at that and we think what's being reported here. Colonization. What is colonization and where is it? What do they mean when they say graft? Do we know where the graft is? Is graft a type of, doesn't mean a transplant? And if it means a transplant, which organ would be affected? Can we find a combination term for this? Some kind of graft colonization. But then what about the Serratia marcescens? Do we need to split code it? Do we even need to seek clarification from the reporter? We may know what the graft is. Then probably is information somewhere in the case about the transplant. If it's a transplant, what the site would be. But we just don't know. So let's have a look and see how we would approach it. How would you code it? I've given you a few here, just a few suggestions. Is it a graft infection? Is it bacterial colonization? Is it a device colonization? So is this graft actually maybe a vascular device rather than a transplant? It could be. Is it Serratia marcescens test positive, or would you seek clarification? So I can see some of you are voting already. Few questions you ask yourself there. What is colonization? What is the graft? And do we capture the test result? Hopefully you'll receive the questions, the examples in advance, so you may have had a chance to think about them before the session. Okay, let's see where your votes lie. Oh, lots of you voted. A difference of opinion, though, on this one. Largely whether you've gone for graft infection. Some of you have chosen bacterial colonization. So we'll talk in a minute the difference between infection and colonization. lot of you've chosen Serratia Marcescens test positive, and a few of you are going to seek clarification, and then one or two of you think it might be a device. So a real difference of opinion. Well done. Thank you for that. Let's see. Well, if we go to Dorland's Medical Dictionary, which is often my first point of call, I'll see what is an infection. So an infection is invasion and multiplication of microorganisms or parasites in body tissues. It may be clinically apparent or remain localized with cellular injury. So what we're saying here, infections remain localized, subclinical and temporary if the body's defense mechanisms are effective. So there is an interaction between the microorganisms and the body. When there's an infection, it has an effect on the body, and the body has an immune response to the infection. But colonization is different in that colonization is the establishment and growth of a new group of microorganisms on a host. So this is on or in a host, but we don't then have the immune system response to it. That's the difference between the infection and the colonization. So infection is more invasive, in other words, invasion of the tissues. Okay, so that's my first thoughts from Dorland's. So there, I immediately am thinking that colonization is not the same as infection, because colonization just means the organisms are growing in or on the body. Here's a reference we found. So this shows you investigation and control of 2 consecutive Serratia marcescens outbreaks linked to devices in an operating room. And we see here that it's commonly these bacteria grow in contaminated medical devices, syringes. Colonized patients is an option, healthcare workers' hands, sinks, and even soap. So it's a very common pathogen to colonize. The early identification of infected patients and other possible sources is important, so as not to spread it or create a colonization. So let's browse MedDRA then at this point. Let's see what we do. I'll go to my browser. So we see here, here's my browser. So I'll go to how to use tools, and I'll go to the new web-based browser. So I'm going to have a look first of all at the terms that we had in our poll. So let's have a look. So a lot of you thought about graft infection. So I can look at the term, but actually there's no infection reported here. So here is, we've got renal graft, skin graft, vascular stent graft. So it supports what we said about a graft could be a transplant, it could be a vascular device. Graft infection is under infections and transplant complications. So it is there. The reason I wouldn't choose that one is that what we have here is not an infection, it's a colonization. So let's have a look for the word colonization. You can either try with the Z or the S, depending on which we want. I'll do the Z because that's what we were given. Usually MedDRA has LLTs at both the S and Z, British English versus American English. So we can see here, what do we have? We have bacterial colonization. We have a few specific pathogens, device, but we don't know it's a device, do we? It could be a transplant. Fungal colonization, bacterial we know it's a bacteria. A few of them are listed. The best of those is bacterial colonization, and it's a bacterial disease carrier at the PT level, infectious disorders carrier at the HLT. So this supports again the distinction between colonization and infection. And when you have colonization reported, it's always important not to assume an infection, but to go with a colonization, because look, MedDRA keeps them very separate there. They're in the infectious disorders carriers. They're carriers rather than being actually affected by the pathogen itself. So there we are. Bacterial colonization is a possibility. Device colonization was one of the options I gave you, but our verbatim describes it could be an artificial vascular prosthesis or a stent, but we don't know this. So unless there's more information in the case, or you could query to find out. We wouldn't assume it was a device without having more information. So there's no Serratia availability there. So let's have a look at Serratia and see what terms we have. Do we have anything here? So we have different infections, so pneumonia, septicemia, bacteremia. Serratia marcescens infection, but we know we're not going to code to an infection. So we're left with Serratia marcescens test positive. It's not ideal because it's not representing the colonization, but it has been done in order to find this. So that is a possibility that we could consider there for that one as well. It is an investigation term. So we'll go to the browser and we'll see it there under investigations. And there it is with other tests. Pathogen test results, positive test result. So I like that because I think it adds more clinical information. I know it hasn't told us that the test has been done. It doesn't explicitly mention that, but our verbatim is so vague. It would be a good idea to query if possible, but if we can't, we may have to do the best we can, which would be the colonization and the test results. So our learning points is that we would seek clarification from the medical textbooks to better understand the reported condition. We would search for appropriate combination terms using top down and bottom up. Top down is where you open the sock itself and look down. Bottom up is where I type it in. And if there's no suitable term or suitable vague term for the reported scenario, you would query. So if I had to make a, without being able to get any more information, I would select bacterial colonization with the spelling that matches the reported event and Serratia marcescens test positive, because as we know, it's not an infection, it's just showing us there's colonization. So that's what I would do with that one. I can see we have some questions. Let me see. So Martin's telling us the internal presence of Serratia marcescens is always an infection. Yeah, but it doesn't internally, but we don't know necessarily, do we, that it is internal. You're saying if it was internal, it would always be an infection. My reference seemed to say that it would only be considered an infection if it triggers a host response, whereas colonization can be harmless. And also the fact we don't know what the graft is, what type of graft it is. So I think I'm still more comfortable with my colonization, but thank you for your thoughts on that one, Martin. And Serratia marcescens infection, well, that follows on from what you were saying. You would also code it as an infection. I'll take that back and we can maybe pick it up again in our next session, but my understanding is that it's a colonization only. I think that's everything then. Any other questions, Leander, that I've missed there? I've had a quick look through the questions. I'll move on to the next one. In the interest of time, the next one's another one carried over from last week, called transplant vasculopathy. As I say, although the graft colonization, if you knew more information in the case, you could probably code it more specifically. The next one is transplant vasculopathy. So vasculopathy, opathy meaning a disorder, something wrong with the and we know it's vascular, so there's a problem to the vascular system. So we went to try and find a reference in medical literature, and we found that transplant vasculopathy constitutes the major impediment to long-term survival, particularly in heart transplant. So with response to immune injury, it can be best understood as the resultant of an orchestrated recipient immune response to the initial allergenic stimulus by graft vascular endothelium. So what this is saying, it's a reaction in the patient to having a transplant, and it's often used in response to heart transplants, in reference to heart transplant. It's where the internal, if we see at the bottom, the intimal fibroproliferative growth of the donor vessel. So the inner lining of the vessels have fibers and things growing on them, and it's the donor. because when you see this, we go back to our first one, we don't know what the body site is. We found a reference that it's commonly heart reference. We don't know if it's before the transplant or after the transplant. Is it the donor vessels or the recipient vessels? So do we need to seek clarification, or can we make sense of it? So as I've explained, the first reference we found commonly refers to hearts. So graft, what is a graft? We're back again now to our Dorlant's references. It's any tissue or organ for implantation or transplantation, or the process of implanting the tissues. So the term graft is preferred over transplant for when it's skin. Well, we don't know again, do we, what ours is, but it's not going to be skin because it's vascular. So it's probably an organ of some kind. It could well be heart. We know what a transplant here. Dorland says it's an organ or tissue taken from the body for grafting. And transplantation is another way of saying the process of inserting it. So we still don't know from our verbatim what the site is, what the organ is, and we don't know where the vascular problem occurred in the donor or the recipient. So let's go to the browser, see what we can find here. So I'm going to look firstly for transplants. Oh, so it's transplant or graft. And also I'm going to look for vascule, let's see that. Transplant vascular, nothing. Transplant vessel, something to do with the vessels, or the maybe artery, maybe. No. Arterial stenosis, no, nothing there. What about graft and all these? Otherwise, we might be, if we can't find a vasculopathy, we might be on to a more general complication term, graft and vascular. Oh, these are going to cardiac allograft vasculopathy. Cardiac, but we don't know. That looks like, let's have a look at that one in the hierarchy. Go to the browser. Cardiac, it's cardiac allograft. It's a complication within injury, poisoning, and procedural complication. It's a procedural related complications. And then down here, transplant complications. So it is listed as a complication, but it's cardiac. And we don't know. It's good that it's got vasculopathy in it. So it makes me think that this is something that does happen following transplants. Maybe it is cardiac, but I wouldn't make that assumption without asking or without knowing more of the case, asking the reporter. Anything else with vasculopathy? Let's have a look down. We've got specific vascular graft problems. Vascular graft, we don't know it's a vascular graftness or vascular stent graft. No. So again, there's that cardiac term, but I'm not seeing anything else really. Otherwise, it would have to be a complication term. And we see here some of the complications down here. We've got complications of in transplanted surgery, heart, liver, general complication terms, complications of transplant surgery, complications of transplanted organ. That may be the best we can find. So let's go back to our slides. Any other thoughts? How would you code it? Would you code it to a vascular disorder, complications of transplanted organ, transplantation complication, transplant dysfunction, transplant failure, complications of transplanted heart? I haven't even given you the term we've just found, heart transplant failure, or seek clarification.
Just while everyone's choosing there, Jane, we had a question. What is your preferred place to search for definitions of combined terms?
combined terms. I think generally as a definition, there are multiple medical books and medical dictionaries. My first point of call tends to be Dorland's Medical Dictionary, but within the MSSO, we do use other references. We use Oxford's for medical, more in-depth medical information. Carol Ann and I use PubMed online when looking for references for medical literature. But as a definitions, I would go to Dorland's. That's my personal choice, but there are multiple references out there.
Thank you.
Thank you for the question. So have you all voted while we're doing that one? Transplantation complication seems to be the most popular there, that it's a complication from the transplantation. And let's see, let's close the poll. 49%, you're more agreed with one another on this one. The learning points is we would search for an appropriate combination term using words, stems, synonyms, quasi-synonyms. You saw me look vascular or vessel, graft, transplant, because we don't know. So transplant vasculopathy. To better understand the meaning of a PT, check the hierarchy. So this would be in relation to the transplantation terms, the LLTs and the neighboring PTs. And if you think it's too vague, you may need to query. So our final option was again to query, to find from the reporter the affected organ, if you don't know that already in the case. And if no further information is available, we would select graft complication or complications of transplanted organ, which falls under the PT of complications of transplant surgery. So the same PT where we were, and we would also optionally code vasculopathy. You might say, well, why is it optional? Because the vasculopathy is related to the procedure. It's not a whole spontaneous in the normal etiology, the normal pattern of events. So that's why you might choose to code it as vasculopathy, but it's very specific to even what we saw in the reference. It's the donor organ. So as it's not a vasculopathy, a general disease affecting the patient, that's why we would say if you want to code it, you could, but we wouldn't necessarily select it. Okay. Any more questions on that one? Leandra, any more questions?
We just had one comment that said, what about losing the term graft?
Oh, because of
searching.
Just look for vasculopathy. We can try. Is that what you mean? Vasculopathy. Lose graft. So we've got some other, that's good. Thank you for pointing that out. We have some other vasculopathy terms, but they're all specific types of vasculopathy or different situations which are not related here other than that one that I mentioned, cardiac allograft, which you could consider if you knew more information about it. And these are the complications of the transplantation. What we're saying here, we saw these, didn't we, before? So we've done that. We can look up. We talked about looking up top down and bottom up. This is what we mean here with the combination of the two. So I'm not seeing anything different, but thank you for your comment. So the next one is one that we were recently suggested. Somebody emailed us with this one. This one is mild dysphagia after bronchoscopy. Mild dysphagia after bronchoscopy. Is this a procedural complication? So is the dysphagia related to the bronchoscopy, or is it a temporal relationship? Can we find a combination term that connects the symptom and the procedural context here? Do we need to split code for the dysphagia and the bronchoscopy, or what would be the most appropriate LLT? So that's how this one, I think, is a simpler one. Dysphagia after bronchoscopy. It's simpler to understand from a medical perspective is what I mean, right? Not necessarily easier to find the right term. So what is dysphagia? You see, again, I go to Dorland's. It's difficulty in swallowing. What is a bronchoscopy? It's examination of the bronchi through a bronchoscope. And there we have the picture from Dorland's showing what can happen. So you're putting the camera down into the, through the mouth, down into the lungs, down into the bronchi. So you can see there why there could be some trauma on the way down. So how would you code mild dysphagia after bronchoscopy? And you can select as many as you wish here. I'll leave you vote. Please, you must tell me if I'm going too fast. I know I go faster than Carol Ann when we do these examples. So if I'm going too fast, stop, let us know, and Leandra will give me a nudge to slow down. So I've given you a selection here. I've given you this dysphagia. I've given you pharyngoesophageal, which is the site, a bit more specific, dysphagia, respiratory tract procedural complication, gastrointestinal procedural complication, post-procedural complication, bronchoscopy, or bronchoscopy abnormal. Well, we don't know anything about the result of the bronchoscopy, so hopefully you won't necessarily choose that one. Let's see then. Nobody's chosen bronchoscopy abnormal. Phew, I'm very pleased there. So what have we gone? We've gone for dysphagia. Yes, that's what's reported, isn't it? Dysphagia. So we code as reported. Pharyngoesophageal, well, we don't know that necessarily. I know the bronchoscope's gone down through the throat, but it hasn't gone into the esophagus. It's gone into the respiratory tract. It is a respiratory tract procedural complication. Well, is it or not? Is it a temporal relationship between the dysphagia and the bronchoscopy? Is it an assumption to say that it was due to the bronchoscopy? It doesn't say due to. And then we have post-procedural complication. GI, well, it's not GI except that swallowing is a GI problem, but it wasn't a GI procedure. And then we have the bronchoscopy. So generally, I'd say your thoughts are similar to ours, generally, and I'll explain a bit when we look at our final suggestion, our final selection. So I'll have a look now in the browser. I'll look for dysphagia. That's the obvious first put. And I'm looking for a dysphagia which might be related to a procedure, procedural dysphagia. So looking down, what do we have? We have dysphagia, we have some specific types, a treatment for it, management of it, choking sensation, pharyngoesophageal, but it's swallowing, so radiation, but nothing related to a procedure, unfortunately. Pharyngoesophageal just codes to dysphagia at the PT level anyway. So dysphagia seems like we need to capture that one. The question is, can we say it's due to a complication, a respiratory tract complication? Respiratory complication, procedural complication. Can we say that? Is it temporal or is it causative? Respiratory tract procedural complication or respiratory complication with device, no device. So this is possible, but it comes to that judgment when it says something happens after a procedure. Can you assume that it's a procedural complication? So what have we decided? So we would ensure that all the reported concepts are fully understood, and that's why I go to Dorland's. Do not assume a link between the elements when only a temporal relationship has been reported. And this example, Carol Ann and I had a discussion before the session because my feeling was that the fact they've told us it's after the bronchoscopy would link it to the procedure, that it would be a procedural complication. But Carol Ann pointed out to me that we shouldn't assume a temporal relationship we shouldn't assume a causative relationship when we're just told that one thing happens after the other. So we had a discussion about it, and we decided that we would capture every symptom separately, and we would capture the procedures following the internal coding conventions, but we wouldn't link them. We would code dysphagia and bronchoscopy. And it may be that you have guidance. If this is something that you see a lot, you might consider adding guidance on how to handle these post-operative complications where it's reported with a temporal relationship in your internal coding conventions. So you might choose, if you know that this is a common problem, you may choose to code them slightly differently and link them together with a complication term. But just with this out of context, we wouldn't choose the respiratory procedural complication term. Okay, hope any questions? Let me have a look.
Yeah, we did have a comment there, Jane. Post is Latin for after, but in the context of dysphagia, is the complication of bronchoscopy or other manipulation in that area?
Is it an assumption? So yes, I know what you mean, Martin. My feeling was the same, that I showed you the picture. You're putting a camera down somebody's tube, narrow, so injury or problem is probably quite likely. I agree, but we felt that for our example, out of context, we wouldn't make the link. But as I say, it may be something that you wish to include, something that companies might have in their own internal coding conventions. But it does mean after, yes, as you say, but in the context, why are they telling us that it's after bronchoscopy if there wasn't a relationship? That was my thinking. So I agree with you, but we've decided to be pure and strict for this training. We've decided not to link them. Okay. Anything else? I've not, don't see anything else. I think.
Thanks, Jane. Or comments?
Okay. I think the one comment went back to the first example that I may have not really understood. But if we've got time at the end, I'll go back to it, or I'll follow up with you offline. So the next one was another example that we were sent very recently, just a week or two ago. Uterine and ovarian transposition. What is being reported here? Is it a procedure or is it a congenital malformation? So transposition means moving something from one place to another, or and something being in the wrong place. So it could be congenital. You have some vascular congenital anomalies where the vessels are in the wrong place, or it could be a procedure to move these organs to a different location. That's what we would see from the first take on this term. Can we find a combination term for uterine and ovarian, or do we need to split code? Do we need to seek clarification to see, is it a congenital anomaly or is it some kind of procedure? And what would be the most appropriate LLT? Again, I go to Dorland's to see transposition. Transposition could be any of various congenital anomalies in which the organs are displaced to the opposite side. Or it could be the operation of carrying a tissue flap, well, that's very specific, or movement of genetic information. So it could be either a procedure for moving, or it could be a congenital anomaly. So go to PubMed, laparoscopic ovarian transposition to preserve ovarian function before pelvic radiation and chemotherapy in a young patient with rectal cancer. It's very sad, but these are when I looked in PubMed, there were several references that shows that this is an operation that's been done for some time when there's a relatively young patient or somebody of premenopausal that wishes potentially to become pregnant after they've recovered from their treatment. They move the reproductive organs, they move the ovaries away out of the path of the radiation. And this is a preservation of ovarian function. Important concern in premenopausal cancer patients whose treatments include radiotherapy to pelvic structures that incorporate the ovaries. It was developed to displace the ovaries from their normal anatomic position away from the direct radiation portal with the goal of maintaining long-term ovarian function. So it is very clearly more likely to be a procedure than a congenital problem because of what it's the position, the report. Another one looking at a uterine transposition. So what's interesting here, if you have a look, the reference for this is only 2025, only last year. Uterine transposition for fertility preservation and ovarian conservation in patients undergoing pelvic radiotherapy. So it's the same concept, but now, because pelvic malignancies and their treatments often compromise reproductive potential, the need for effective fertility preserving strategies has become increasingly important. So uterine transposition is an innovative surgical technique designed to preserve fertility by safeguarding both the uterus and ovaries in patients undergoing pelvic radiotherapy. The approach involves temporarily repositioning the uterus and ovaries outside the radiation field with reimplantation after treatment. Very interesting area, this. So we see that uterine is a newer operation. So which would you choose? Would you choose ovarian transposition, uterine operation, fertility preservation, visceral transposition, female genital operation? What I omitted to tell you is, and I'll leave you do the poll, when you go to the Medra browser, we don't have a term for uterine transposition. We only have ovarian transposition. That's why I haven't given you uterine transposition in the choice of options. Okay, how are you doing then? I've got some, we'll have a browse in a moment to have a look. Okay, let's see where your votes are. Ovarian transposition, good. We've had that reported in the verbatim term, so that's definitely one we would choose. I would look for uterine transposition. If it was there, I would select it, but it's not. So uterine operation might be the best we can do. Fertility preservation, well, it's the reason for doing it. So do we need to select that? It hasn't been reported, but I agree with you, it is the reason. Visceral transposition, hold that thought. Those of you who chose that one, I'll show you in the browser. Or female genital operation, I think is a bit too general for my liking on that one. But let's have a look in the browser. Thank you for your votes. I'm going to try and slow down a little bit because I think I've probably gone a bit too fast. So let's browse for transposition. So we've got a number of transposition terms. Abdominal, gastric, intestinal, ovarian, there it is. The ovarian transposition is at the PT level. It comes under fertility and fertilization interventions, female. So that supports what we saw in our medical references. We see some other transposition terms. Transposition of great vessels, visceral transformation. So viscera are internal organs. That has a PT of heterotaxia, but it has an HLT of congenital disorders. So let's have a look at this one. Let's go to the browser because visceral transposition sounds like movement of internal viscera. Heterotaxia is a congenital problem. Look, it's in the congenital sock. So this illustrates nicely how sometimes you can find an LLT that you think looks like could be a quite good choice, But look where it, only when I look at the hierarchy, I see that it's completely inappropriate. It's a congenital problem. So don't just find an LLT, copy it and code without checking the hierarchy when you're coding. That's one of the most important tips we can give you for coding. So that one would not be suitable. So we've got our ovarian transposition here. Let's go to the browser and see that one. Ovarian transposition. It has nothing else underneath it. And as we saw, it's under the HLT of fertility and fertilization interventions. Is there anything else there that could capture either the whole of the operation or something relating to the uterus? No. Management of reproduction. It would only be, we would have to use that term that I was telling you, the preservation of reproduction. No. So then we come to the uterine surgery or uterine operation, uterine therapeutic procedures. Well, that might be the best we can do, because I'm not seeing, I would want something under here really. And when we looked at the reference, what was interesting was the uterine transposition seemed to include ovaries with it. So if it was there, we could have selected that one, but we don't have it. Now, as soon as I see that, it makes me think maybe it's something we could request as a new term to be added to MEDRA. So this is where, and I know our inquirer, one of our regular attendees, sent this in, and they were thinking the same. They were going to request it to be added to MEDRA because they came across it. They did the referencing just like we've done, and they requested it to be added. So heterotaxia, just to show you, to reconfirm what we saw, heterotaxia syndrome are congenital anomalies. So what this is goes back to what I was telling you. Don't see a term that looks good at the LLT level and then select it without checking the hierarchy or referencing it in Dorland's. So what have we learnt? Uterine transposition is a relatively new surgical procedure and involves temporary displacement of both ovaries and uterus. Only ovarian transposition currently exists in MEDRA, but a new LLT and PT has recently been requested for the new surgical procedure. This is very much hot off the press. Here, this is what you can find yourself within the WebCR tool. This is where you look at searching the change request history. You can see that the new PT was requested of uterine transposition under the HLT we looked at, fertility and fertilization interventions female. And the final action was that it was approved, not exactly as requested. What was added was uterine transposition procedure. That's to make it very clear at the LLT level that this is a procedure and not a congenital problem. I know that the existing ovarian term doesn't say procedure, but for clarity, to be as clear as possible going forward, our IMO team, our international medical officers, have decided to add the word procedure, and there it is. And you have the note at the bottom. It's not uterine transposition is a procedure for preserving gonadal and uterine function, exactly what we know there, for pelvic radiotherapy for non-gynecological cancer with the potential for achieving spontaneous pregnancy and successful delivery. Okay, so nice example there of where a new concept comes along. Thank you for suggesting it, that we use it for the session. And this is exactly what happened. We would code it to the LLT-PT of ovarian transposition, and we would, and also the uterine operation. But we would potentially, you could, if you wanted to do the uterine operation, and then we would split code it to the new LLT-PT in the future when it's available in version 29.1 in September. The reason it's September is because the request missed the December deadline to get the change into version 29 in March. Any questions on that one or comments, Leander?
Not that I can see, Jane. No comments on that one.
Thank you. So now I'm often asked, can you do narratives? Can you do bigger examples, bigger patient case studies? So what I've put together for today are 2 examples of narratives. I just want to do a short disclaimer. I'm using these to illustrate the use of Medra for coding different types of data. They're not intended to demonstrate how data should be extracted and entered into your database for any reported case, because this depends on your local regulatory guidance and your own organization's data entry conventions. So this is very important. I'm only using these for a Medra training perspective. So the first one, a 43-year-old female with a history of controlled asthma took a standard dose of over-the-counter analgesic for a headache. Her medical notes state she had experienced mild drug-related urticaria in the past after taking the same ingredient, but she'd forgotten this when she accepted the tablets from a friend as the packaging looked unfamiliar. So we've got the start of our story here. We know the medical history is asthma, and we know the indication for the analgesic is a headache. We know that she also has a medical history of drug-related urticaria in the past, but she missed this. She forgot it. She made a mistake when taking the tablets from the friend. So this is what we would code: controlled asthma, headache, and the mild drug-related urticaria. I'm not going to code every one because it will take too long. They're straightforward terms. We would search using the reporter's words. Because it says controlled, I would look for controlled, because there are some LLTs in Medra that do use the words controlled or uncontrolled. So I would search for that. And the severity criteria are out of scope. So the mild is not something that I would expect to see in relation to the LLT when we find it, because that's a severity criteria or severity qualifier, which are not included. Term suggestions. I would code to asthma, headache, and urticaria drug-induced. Now, interesting, there aren't many terms in Medra that have drug-induced with it, but urticaria is one. So because of the nature of it being so important for allergic reactions. So we must always check, if you see drug-induced, check just to be sure there isn't an LLT. Is that everything? Is it important? Is this a product monitoring error? She forgot that she had a history of problems. And was there packaging confusion? She said that she didn't recognize the packaging. Was she confused? Well, let's consider these 2 questions. Is there anything else to capture? Is it a product monitoring error? Well, there is mention that there's documented hypersensitivity to a similar product administered in the past. It said in her notes that she'd had a problem. The patient had overlooked it. So is that an error? I think that is an error. It's a product monitoring error by the patient. Is it packaging confusion? There's no mention that she was confused by the packaging, only that it was unfamiliar. So my feeling is that it's not a packaging confusion error, just that it's the product monitoring error. So here's the point we're looking at here. She'd experienced mild urticaria in the past, and it's in her medical notes after taking the same ingredient, but she'd forgotten this. The packaging looked unfamiliar. Her medical notes state, so with this, what would you code? Would you code it to product appearance confusion, documented hypersensitivity to administered drug, a medication monitoring error, similar reaction on previous exposure to drug, and urticaria drug induced? So the text that I've given you here, how would you code it? Yeah. Has everybody had chance? Let's see. You can carry on voting. It's still open. Urticaria drug induced. Yeah, absolutely. I hope you all chose that one because we know that that's part of our medical history. But what about the others? Is it we're split, aren't we? We have difference of opinion there. Some people think it is a confusion by the product. I'm not sure that I would code that because that would be a medication error, confusion error. I'm not sure. She was confused. She just didn't recognize it. Documented hypersensitivity to administered drug. That means that the drug has been given in spite of it being in the notes. So that is a medication monitoring error. So we don't necessarily need to code both of those. The documented hypersensitivity is more specific because we're told it's in her notes. And then similar reaction on previous exposure. Well, similar reaction, we don't really know yet have we been told if it is a similar until we find out more of the story. We don't know necessarily. It probably is a similar reaction, but I'm going to hold that until we find out more of the symptoms that she developed later on. So let's close the poll. I would code here documented hypersensitivity to administered drug, which is under product. It is a medication monitoring, I can show you, and I would consider similar reaction on previous exposure to drug because I would need to assess what symptoms arise on this occasion. So we're going to learn more about this lady. I'm going to show you where documented hypersensitivity falls. I'm also going to show you that it's documented hypersensitivity to administered drug. There it is. It's product monitoring errors and disuse under medication errors and product use errors and disuse. So it's an error or issue, whatever you want to call it. She forgot, so I think that captures it. If this term is one you come across and you forget what it means, you can go to the MEDRA concept descriptions within the browser. And it's interesting that that term is actually there because historically over the years, we've had so many people ask us, what does this MEDRA term actually mean? That we've put it there. So you find it refers to a situation where the patient is administered a drug that's already documented, but and it's given anyway. I know it's mentioned here physician, she took it herself, but it's the same thing. Error can be by the physician or by the patient. So that's what I'm going to do with those. So hold that thought, and we're going to find out part B now. 2 days, Leandro, could you put part B in the text for us? 2 days after taking the tablets, she developed a high fever and a stinging sensation in her eyes. So we're learning more about the symptoms. Several hours later, a red macular rash appeared on her trunk and spread to her limbs. So she's now getting a rash. So we were told before she had urticaria. So now we're going to be able to assess in our mind, is this a similar reaction? It's sounding quite like it to me. So let's take our, I seem to have lost. Oh, sorry. I seem to have a bit of a delay there on my internet. So let's see. We're going to code high fever, stinging sensation in her eyes, and red macular rash on the trunk and limbs. Those are what I've selected from the, let's go to the browser. So we've got the high fever. So we either have high fever, no results. So we can try high temperature. High temperature has a PT of pyrexia, febrile disorders. Let's go to the browser to see the options there for that one, because it seems like, is there a more, we're in febrile conditions. There's pyrexia as the PT. Underneath it, this is where we find we've got fever or we've got high temperature, and we've got lots of other ways of describing it. There's low grade fever, but there isn't a high fever. Slight fever. This is one of the few terms in MedDRA where there are what I would call severity, if you like: high fever, low fever, subfebrile, slight fever. So that's the PT is pyrexia, and I would probably choose fever under that one. The next term we have is stinging sensation in eyes. So sting eye, let's try that. Can we find something? We find an almost identical term, stinging sensation in eyes, with a PT of eye pain. So that seems like an almost exact match. Always try to match with the exact wording if you can. And then we have the rash. So it was red and it was macular. So let's try macular rash. So let's look what we have. We have excuse me, a diffuse macular rash, erythromacular rash. That's a nice one because erythro means red, so that captures the erythromacular rash. We could look down, there's maculopapular, maculovesicular, different ones. Erythromacular looks good. We haven't captured the limb or the trunk. So I could look for rash on limbs. Rash on trunk and limbs is a non-current term. You see the red box, so we don't choose that one. And that would lose the specificity of the macular rash. So that's not good. Rash limb, rash trunk, I can do just to show. So MedDRA, in the points to consider, they tell us that we've got erythropapular rash on trunk there, but it starts, what were we told? It goes to rash papular. So we could look at that one, but we're then specific to trunk. We're told it started on her limbs, weren't we? So I would probably stick with erythromacular rash on that one. You do have it for trunk, but I wouldn't just code rash on trunk. It's more important to capture the nature of the condition than the site of the condition. So 3 days later, on the third part now, 3 days later, she was admitted to hospital as the rash had evolved into large blisters, and they'd given us the description of bullae. Her skin began to peel away in large sheets when touched, which was documented as a positive Nikolsky sign. Upon examination, she had epidermal detachment covering 30% of her body surface, with mouth and eye mucosal involvement. So we've got a lot more happening now to this poor lady. So we want to code the blisters or bullae. Our blisters bullae is what we're going to do with this. Then we've got the peeling skin, positive Nikolsky sign, which sounds like it's a clinical sign. It might be in the investigation SOG. And then the epidermal detachment covering 30% of her body with mouth and eye mucosal involvement. So I've picked out what I'm going to look for. Large blisters or bullae, skin began to peel away, positive Nikolsky sign, and epidermal detachment with mouth and eye mucosal involvement. These are the 4 concepts. So let's browse again. I'm on my third section. So we've got blisters or bullae. So let's look up bullae. We'll see shortly, the points to consider document tells us that when you have a report of a combination term where you have a bullae comes in there as an LLT and the PT is blister, when the points to consider says when you have a combination report and it includes two descriptions, for example, blister and bullae, if one is more specific than the other, code the more specific one. So I think on that I would code the bullae. But we see that the PT is blister. There's nothing about drug induced at this stage. We've got other bullae for different sites, but that seems to be the best match we've got there. Then we've got the peeling. Her skin was peeling. Again, use the word peeling. We've got peeling, nail peeling, scalp skin peeling with a PT of skin exfoliation. That seems like a good one. We've got our Nikolsky sign, Nikolsky sign. We have a positive, negative, and a test. The sign itself it was recently actually made non-current because we decided that we would make the LLTs more clear whether it's positive, negative, or just the test. Nikolsky sign was too vague. So we know that it's positive, and we can see that that's the PT as well. It's an investigation. I can go to the browser and can see in this investigation. And I'm going to talk about the PTC guidance when we come to the end of the example. So in case you're thinking, why am I coding a test result if at the moment, I can't find it now. Skin hair. Come on, what have I done wrong? There we go. Nikolsky sign positive is the PT, and that's all we have underneath it. It's skin histopathology and skin investigations within the investigations SOC. We were there before, that's why I got confused. And close that one. There it is. It's within investigations. And then the last thing we had reported there was the epidermal detachment. Epidermal detachment. Is this the same as peeling? It makes me think. No, only something to do with the graft. We've done no graft. Skin detachment. Detach. Anything detached? Oh, too many there. Detachment. Skin detachment. Still a lot to look through. Oh, too many to look through, so I'm not sure on that one. I may move on and we'll come to skin graft detachment. No, I think that one might be peeling. My head is thinking that one's probably good enough, but let's have a look. So Nikolsky sign is ready separation of the outer layer of the epidermis from the basal layer by sloughing of the skin produced by minor trauma such as sliding or rubbing pressure on the skin. This may occur in these diseases, pemphigus, hereditary blistering, toxic epidermal necrolysis, and thermal burns. So this can happen for various reasons, but it's separation with slight trauma, the skin comes apart. So Nikolsky sign is capturing the fact that this epidermal detachment. So I'm not going to worry too much about it. Another option might be epidermolysis. So I had a look around before coming. This is a loosened state of the epidermis with formation of blebs and bullae, either spontaneously or following trauma. So that sounds quite a good match for me. So let's have a look at that one. Epidermolysis. Lysis is a kind of a destruction or peeling, dissolving, or something like that. Epidermal necrolysis. Epidermolysis. It is the exact match. That's under the PT of epidermolysis, bullous conditions, and skin autoimmune conditions. So let's go to the browser and see where it is. There it is. It's under bullous conditions. So that might well be the one we want, epidermolysis. Okay, let's carry on. I lose myself otherwise. So bullae, blister, skin peeling, skin exfoliation, Nikolsky sign, epidermolysis. The narrative, last part now, she was diagnosed. We now have a diagnosis, toxic epidermal necrolysis. That fits because that was what Dorland's told us is one of the common causes of the peeling, of the big peeling, the epidermolysis. And this is considered to be a type 4 delayed hypersensitivity reaction to the over-the-counter drug. So we now have the full story. We've got our diagnosis and we know the cause. So here they are, toxic epidermal necrolysis, type 4 delayed hypersensitivity reaction to the drug. And I would code that to toxic epidermal necrolysis and delayed type hypersensitivity, which has a PT of type 4 hypersensitivity reaction. So what's interesting is if you look at the LLT, it captures the word delayed, but the PT concept is type 4 hypersensitivity reaction. And that's what we were given in our verbatim term. I'll just show you, there we are, type 4 delayed hypersensitivity reaction to the drug. So putting all this together, I considered all the elements reported. I coded the medical history and the adverse events separately. I considered in-house data coding conventions and entry conventions and coding conventions. And this is what I'm saying to you. You must, then this is why we often don't do narratives like this, because people want us to teach them how to extract events from the narrative. And that's not what we're here for. We're only here to teach you how to code to MEDRA. So you have to follow your own conventions and also your local regulatory requirements for the coding and the submission of cases. And I'm now going to, looking at the fourth bullet, I'm now going to apply coding guidelines from the MEDRA points to consider, MEDRA term selection points to consider. So what have we got? We've got an indication of headache, a medical history of asthma, medical history of urticaria drug-induced, a medical history, I'm happy now I've seen the full case, that it is a similar reaction on previous exposure to drug, and that there was a monitoring error, documented hypersensitivity to administered drug. The symptoms were fever, stinging sensation in the eyes, and erythromacular rash. We were told that she was hospitalized, but hospitalization is a seriousness criteria. I didn't bother to code that one in the list, but we could have coded it. But we'll see how the points to consider document mentions hospitalization shortly. The symptoms were bullae, skin peeling, Nikolsky sign positive, epidermolysis as a clinical sign with a diagnosis of toxic epidermal necrolysis and delayed type hypersensitivity. So what do we learn from the points to consider document? Well, points to consider says if it's a confirmed diagnosis and you have signs and symptoms, you should check whether the signs and symptoms are characteristic. And if they are, the preferred approach is just to code the diagnosis. But it's equally acceptable to code everything. And sometimes by coding everything, you can use medical judgment that it might give you more clinical information. And that's something to bear in mind with hypersensitivity. In the points to consider document, it says, if splitting the reported adverse event provides more clinical information, select more than one MEDRA term. So this is what, if you get more clinical information, you may want to capture more of the elements, more of the symptoms. Are the symptoms that this lady had typical of toxic epidermal necrolysis? What is it? It's an exfoliative skin disease seen primarily in adults as a severe reaction to a drug, although it may be caused by infection, neoplastic disease, or chemical exposure. It tells us that the subepidermal separates, bulla, inflammatory changes, leaves the skin raw. Very, very nasty. I found a reference as well on DermNet that we sometimes use, again, looking for the symptoms, explaining that it's above 30% of the skin surface and mucosal involvement, erythema, necrosis within 2 days, and it tells you there the difference between Stevens-Johnson syndrome if it's less than 10% of the body, and toxic epidermal necrolysis if it's greater than 30% of the body. Okay, so I'm happy with everything so far. So also in the points to consider document, they tell us that death, disability and hospitalization are outcomes or seriousness criteria, not usually considered adverse reactions or adverse events. So we haven't coded hospitalization. And if the event occurs at multiple body sites, I mentioned this before, where we saw the erythromacular rash, I'd rather code the erythromacular rash rather than saying it was a rash on her limbs or a rash on her trunk. If you have an investigation result which is consistent with the diagnosis, so this is our Nikolsky sign, the points to consider says that you should only code the diagnosis. There's no need to code the investigation result because you have the diagnosis. So we see here with a simple example of potassium and hyperkalemia. So you only code the diagnosis. So if we apply all of these learning points, we would code the indication, the medical history, all three there, the medication error, the diagnosis, but because this diagnosis can be spontaneous or it can be due to drug, we also want to code the delayed type hypersensitivity. However, it is equally acceptable to code the symptoms. And when you have the case in front of you, you see the dates, the onset dates. It may be that when you look at everything, or it may be that with medical judgment, you decide to code all the symptoms, and it would be perfectly acceptable to code all of these as well. Right? Happy with that? Anyone got questions or anything you want me to go over again? And I just brought along a little slide here that shows, I found on the web, explaining the difference between type 1 hypersensitivity to type 2, 3, or 4. And Medra has terms for some of these, types 1, 2, and 4, I think. Let me have a look. While you put your questions in, I'll show you what we have. We can have a look under hypersensitivity. That's why with hypersensitivity, any reports of hypersensitivity, it's very important that you know the type of hypersensitivity, find out the symptoms, because symptoms can range. We see here so widely the symptoms. So find out as much as you possibly can. We have hypersensitivity type 1, type 2, and I think we have type 4 as well. I saw somewhere before. Type 1, type 2, type 3, and type 4 down here. There they all are. Type 1 hypersensitivity, type 2, type 3, and type 4. So you see very different. They're at separate PTs, and it's always important to capture as much as you can. Okay, any questions?
We do have a few questions. Thank you, Jane. Taking the first one, would you code controlled asthma as asthmatic instead of asthma?
It doesn't matter. It has the same PT. I can show you. I would code asthma because it's asthma is the wording. The disease given in the asthma is the LLT. There's the PT. If we look down, you were suggesting asthmatic. I think it's the same PT. PT of asthma, exactly the same.
Thank you. And we've got quite a few questions.
Oh, okay.
I found the following term: a product prescribed by unauthorized provider. Would you consider adding this?
No, because it's not a prescription drug. We're told it's over the counter, and we don't know anything about anything being prescribed by anybody unauthorized. So no.
Thank you. Would you choose it despite that the drug was not the same?
Yeah, because we were told it was the active ingredient was the same. So based on that, I would. But again, you might have guidance if it's your drug and you're dealing with it as the suspect drug, it's your company, you might have internal guidance for handling these.
We had a question that your term types in your chart that you put up, where do they come from?
These, I just made them up. These, what are symptoms, clinical signs, medical history, diagnosis? Is this what you mean?
Yeah.
I just use them to describe what we were dealing with. They haven't come from any official regulatory document. None of this is official regulatory. It's only to illustrate how MedDRA can be used in the whole case for different types of data.
And then we've had stinging in eyes may not be considered classical for 10.
So in that case, that one, a good point. Thank you for that. That's something which could then be pointed out. It could, although it may be part of the delayed type hypersensitivity, it may not be classical. So we could, that's one that you would think about coding separately. Yep.
There's one here from Martin to highlight the difficulty of deciding what is a symptom of the diagnosis in question.
Oh, I think that relates to the stinging in eyes, highlighting that it is really important. Thanks, Martin. It's really important that you do look at every single symptom, and it does get very involved and very complicated. And that's why some companies, even some regulators, adopt the alternate approach, and they code everything because they think, well, nothing's being missed, we're consistent. But it means when you do your analysis, you've got more events in your database. So when you use the SMQs, you're going to retrieve more results. I was going to show you the SMQs actually. Any more, Leander?
Let me just, you show the SMQs while I'm
Okay.
just sorting through. I
just wanted to make the point, we know we were in the coding today, but I just wanted to point out to you that because I was saying hypersensitivity is very important, even at the SMQ level, we have a separate SMQ for anaphylactic reaction versus down here hypersensitivity. So you see the hypersensitivity SMQ itself. So it really is very important that you code hypersensitivity as accurately and as consistently as possible, capturing as much information. And sometimes when we do training, we have some examples where if all you know is hypersensitivity and you know symptoms, we would code the symptoms, even though we're adopting the preferred approach, because you want to know exactly the nature of the hypersensitivity, because it is so vague to just say hypersensitivity. Any more, Leander, before I move on?
Yes, there are some. Just bear with me.
Well, while you do that, I'm going to move on. I'm going to skip the next example, and I'm going to do the ones at the end, because we had some sent in, and I'm going to do those, and the next one, I'm going to jump to here. Okay.
Could you also, Jane, go back to the previous example? And I know you mentioned the new term being added in version 29.1, but could you just answer what you would code now again for?
I would code ovarian transposition, and I would code, I think for completeness, I would code uterine operation. I didn't have that on my slide, because I thought, well, the most important part is they've moved the uterus, but they've moved the ovaries, but they've also moved the uterus. So I would code ovarian transposition, uterine operation, and then next September I would switch out of uterine operation for uterine transposition.
We've just been asked, will we share the slides after? You mentioned that at the beginning. We don't share the slides for Let's Code, but you can watch back of the video.
Because normally we have more discussion between Carol Ann and myself, and so we think that there's more value in the in the discussion.
Thank you. We've also had one from Martin that said we have had a finding in that direction telling us hypersensitivity is not a true diagnosis and we should code the symptoms.
Oh, that's interesting to hear. Thanks, Martin. So it reinforces what I was saying. When you have hypersensitivity reported, that's based on an inspection finding. So that's really good to learn from. We can all learn together from that. That's good. In our training course, where face-to-face training, we tell people when you have hypersensitivity, always code the symptoms as well. And we see there how important it is. So I'm conscious of time. So you've had a lot of questions all together there. So what we've done one of these narratives. I have another one that I sent out to you. So we will do that in May. Otherwise, we'll be here for another half an hour. I'll do one of the examples that was sent in from one of our attendees. They sent us 3 or sent us a few. So I'll do one of them. We'll do the other 2 next time. So this one is could not swallow study drug due to fear. What's being reported here? Can we find a combination here to capture the fact they can't swallow the drug and it's because of, can we capture this together? Do we split code or what do we find? So let's do one poll for you and then we'll wrap up. What would you do with this one? And we will do, if they were your examples, we'll do them in May. I'm sorry we've run out of time. We'll carry over in May. I thought we might be able to squeeze them in there, but with all the questions, we didn't have chance. Oh, let's see where your votes are lying. Is it choking? Is it unable to swallow the product? Unable to swallow? Fear? Procedural anxiety? Or swallowing difficult? So mostly you're coding unable to swallow and fear. Well, that's what's reported, isn't it? Some of you've selected procedural anxiety or product difficult to swallow. Well, that might be a bit subjective. Is it that the product is difficult to swallow? Because that would be a product issue, really, but it's because he or she is scared. So let's move on. Overall, you've captured the 3, unable to swallow, fear, and procedural anxiety. So let's browse. I will be quick. I know we're over time. I will be quick. So let's look at our last one. Well, I'm going to browse swallowing to start with. We're back on our difficulty swallowing here. Let's look at swallow. So we've got swallowing difficult, swallowing discomfort, swallowing disorder, swallowing impaired, swallowing spasm. Well, it might be a spasm, but we haven't been told that. Unable to swallow. So they're all going to these, difficult or unable, they're all going to code to dysphagia, swallowing impaired, dysphagia. So is there anything which suggests that there's a psychogenic or a procedural or something relating to her brain, the fear? I'm not seeing anything here. So let's search for dysphagia and see if there's anything relating to psychogenic due to mental state, the fear. Only dysphagia there. So let's go over to look at the browser to check. Is that, I'm in SMQs. Let's try again. Dysphagia. I forgot I'd left it in SMQs. Dysphagia. Anything there? Different types of dysphagia. We looked at these before. Let's look up swallowing again to check if there's anything in swallowing when I'm not in SMQs. Product difficult to swallow. That some of you like that. That's a product use complaint. I don't feel it's fair to blame the product really there, that there's a problem with the product. She is finding it difficult to swallow, but we know the reason for that. So I'm not so keen to select that one. Unable to swallow, difficult, impaired. So this is where we're going. So let's have a look at all the terms under dysphagia, swallowing disorder, dysphagia, right-hand click, go to the browser and let's find the best one. So we have dysphagia, swallowing difficult, spasm, a few of them there. I think dysphagia is probably the best we're going to come up with. And then we also have the fear. Should we do fear? Is it procedural fear? Is it procedural anxiety? So fear, there's fear of needles, fear of surgery. There's nothing relating to fear of swallowing or fear of treatment in general. So fear itself has a PT of fear. That's under fear symptoms and phobic disorders. So that's a possibility, fear. Or we could look up anxiety and see the procedural anxiety, anticipatory anxiety, but that's not necessarily a procedure. It's just afraid of something that's going to happen shortly. Post-operative, procedural anxiety there. That one might be a better one than the fear, although fear is what's reported. We'll have to see. So what we would learn is look for a combination term. Look for something like psychogenic or something like that, with saying that it's the swallowing is due to a psychological issue, or in this case, the fear. If not possible, split code and select terms for the swallowing problem and the fear separately, but make sure that all the relevant elements are captured. Check the context, and if this comes from a phase 1 clinical trial, it may be that you have a coding convention for these. Say it may be related to your drug. You might have, if it happens quite commonly, you might have a convention just to ensure that you're always consistent in how you code them. Query to confirm whether the study drug dose has been missed. So make sure that we don't miss that something there has the dose has not been given, because that might be equally important to capture. So I would select procedural anxiety and unable to swallow with a PT of dysphagia, because that's what's reported. I wouldn't code fear because that's more of a phobia type concept. I think it relates to the procedure. So I would select, with medical judgment, I would select these two, but I would look for a psychogenic type thing for the swallowing, but there isn't one. So that's that one. So that's the end of our what we'll do today. We'll save the others for next time. Just as a reminder for you, we do a survey. You'll get a survey afterwards, and I'm also going to give you the option here to suggest some topics you want us to cover next time. All of our past sessions are on YouTube. Caroline will be back in May. Don't worry, you won't have me on my own again in May. She will be back and we'll do the discussion together. Thank you though, Leander, today for your support. The survey should be open for you. You can email us as well if you want to send us some ideas for next time. I can't do your coding for you in the interval, but I can consider some of your examples for next session. You can join us on WhatsApp groups. Here they are. I've shown you where the YouTube. One more thing I want to mention. Let me give you the survey. One more thing I want to mention is sometimes in the survey, people ask us, could we do Let's Code Together live? Could we have a face-to-face Let's Code Together? So we're not offering you a face-to-face Let's Code, but what we are offering you is, following the European user group in April, which is being held in the UK, we're offering you a day of practical coding for both Medra and WhoDrug. So this is the closest we can offer you at the moment for Let's Code Together live. It will have some elements of the Let's Code Together style. It's focusing on the practice of using Medra rather than just the background to Medra and some of the other points to consider and things like that. We're applying the points to consider rather than just teaching you them with a slide. So that's what I've tried to explain it. There will also be some pre-work to make sure everyone's at the same stage coming into the class. We'll ask you to watch some videos and attend a short webinar of 1 hour just to touch base and meet your fellow learners before the class. So that's what we're offering you in April. It's open, it's available on the schedule page. If you're coming to the user group and you want to stay on for another day, you can come to that. You'll be very welcome. So that's just for those of you who do say, could we meet and do this together? That's the closest we're able to do at the moment for a Let's Code Together live. Okay, I'm well over time. I'm very sorry. I will let you all get on with the rest of your day. Thank you for your participation. Thank you for all your questions. We will cover the other examples in May. And in the meantime, send us any ideas you've got for either the live face-to-face as well as the examples in the next Let's Code.
Just one more, Jane, before you go. Sometimes we might receive first the symptoms
Oh.
and then the diagnosis comes later. Shall we delete the coded symptoms once diagnosis is clear?
People usually have their guidance on that. Some people do, some people don't, as far as I know. So I think that's something for, generally, I think people don't delete the symptoms, but that's, people have ways of handling it internally.
Okay, and for those interested, if you go to our schedule page on the face-to-face, you'll see Hatfield, United Kingdom, England. There's 2 sessions and you can register for the practical coding. Jane's just showing you where to register because we've had a couple of questions. Where do we register?
Please come along. We'd love to meet you live, face-to-face, and literally do what we do here, discuss the examples face-to-face. So although it's a training course, it's going to involve a lot of discussion. And here they are, United Kingdom, practical coding. There are 35 and 38 places left. So please do. In fact, it's quite recently been advertised. So there's still lots of places.
That's great.
And you get your certificate from the self-service application after 48 hours after the class. Don't email us and ask for it before that. So it'll probably be Monday.
Perfect.
Thank you very much. Enjoy the rest of your day, everyone. See you all in May at the session, if not before, at the user group. Take care.
Thanks, everyone. Bye-bye.